I think everyone at the beginning understood universal health coverage to mean universal financing. And there was actually a very big push to use NHIF. And very quickly down the implementation journey, it became quite clear that not all the 4 counties were ready for implementation through NHIF. But even further than universal financing, one needed to really understand what service delivery meant. So the finances are there, or at least the cost has been taken care of. But operational efficiencies at the facility level look different in different counties. For example, supply chain of non-pharmaceutical and pharmaceutical commodities, which is one of the biggest consumables that's used in a facility, is a critical component that wasn't taken care of overtly. What had happened is the arrangements prior to the UHC pilots, and by that I mean devolution, had allowed the counties to engage whichever providers they wanted to in terms of commodities for the facilities. But the UHC pilot design that we had made hadn't taken that into account. So what happened is, yes, care is free at the point of delivery. Yes, we've tried to bring in some commodities, but the exact commodities that are needed for this equipment, and I'll maybe just get into the details for those who will follow. If you were to take laboratory equipment, for example, for taking blood tests, these require specific reagents depending on the specific machine you have. But you'll find in one county, for example, we had 40 different machines, which means 40 different suppliers. And, you know, on the back end, when we were trying to avail commodities so that care can be free at the point of receiving, we didn't take into account that there would be 40 different suppliers, right? And these realities on the ground really made implementation quite unique in different counties. In other in other counties, for example, the registration to NHIF, even prior to the pilots, was quite high. But what happened is when you give people care free at the point of delivery, then they deregister from a voluntary scheme, which is what our NHIF was at the time. So that kind of negates, you know, a previous policy that was going well is negated by a policy intervention that you're working on now. These learnings were really critical when we were considering scale up, because then you really needed to understand the community, the county that you're dealing with, what is their predisposition to interventions that are already in place, what are their purchasing arrangements, and so that the policy intervention you're introducing is not negating gains that have been made before. The cross-county learning was encouraged. You know, we had roundtables where, especially at the top level of the counties, the governors, the leadership of the various hospitals would meet and discuss what exactly is happening. They weren't always immediately transferable because, as I said, the 4 counties had different arrangements. But what did come out clear is that even if you avail financing, i.e. you take away the cost barrier for the patient, you must really make sure that at the operational level at the facility, there is a level of autonomy that the facility can exercise to procure what it needs when it needs. I've given the example of laboratory equipment. For another facility, what was missing was firewood to cook food for the patients. For another facility, what was missing was fuel for the generator, for backup electricity. It's not possible to, you know, almost imagine all these various scenarios for a very high level. So this was a very, very important learning that's carrying forward even as we have scaled up. But as we continue thinking about a continuous improvement in the health sector, this facility autonomy to procure what I need when I need it, because the needs for operational efficiency at a facility level are really unique and diverse. They're not what they were 1 hour ago. They're not what they were 1 week ago.